All right, everybody. Good morning and welcome to our side event. I have the great honor this morning of I'm going to introduce Ambassador Mathilde Aku Alamatu, and from the ambassador from Ghana. Ghana has been tremendously supportive of this issue. They co-sponsored a side event for us last year, and they're generously doing it again this year. And Ghana will be hosting the next African Palliative Care Association conference. So, Your Excellency, you have the floor to open this side event.
Thank you so much. It's really, thank you so much, Catherine. I was looking.
I know, where's my thing?
It's an honor to be here with you today to deliver these opening remarks on behalf of Ghana at this very important side event, marking 10 years since the adoption of the 2016 United Nations General Assembly Special Session Outcome Document on the World Drug Problem. Ghana is pleased to co-sponsor this discussion, as Catherine rightly said, together with Belgium, Chile, and South Africa, in collaboration with the World Health Organization, the International Narcotics Control Board, the International Association for Hospice and Palliative Care. We also recognize the valuable contributions of many civil society organizations working to advance equitable access to palliative care worldwide. In 2016, UNGASS outcome document reaffirmed the critical principle at the heart of the International World Drug Control System that controlled substances must be available for medical and scientific purposes, while preventing their diversion and misuse. Chapter 2 of that outcome document highlighted a persistent global challenge, ensuring adequate availability and accessibility of essential medicines, particularly for pain relief and palliative care. 10 years later, this challenge remains significant. In many parts of the world, including in developing regions, patients suffering from cancer, severe injuries, chronic illness, and other life-limiting conditions still face barriers in accessing essential medicines needed to alleviate pain and suffering. These barriers may arise from regulatory constraints, supply chain limitations, affordability concerns, insufficient training of healthcare professionals, and lack of awareness among both providers and patients. For Ghana, this issue is not abstract. As a country committed to strengthening universal health coverage and improving health outcomes for our population, we recognize that access to palliative care and essential medicines is a critical component of a humane and effective health system. Ensuring that patients can receive appropriate pain management and compassionate care is not only a medical obligation, it is also a matter of dignity and human rights. At the same time, Ghana remains firmly committed to upholding the objectives of the International Drug Control Conventions, including preventing diversion, misuse, and illicit trafficking of controlled substances. Achieving the appropriate balance between access and control is therefore essential. In this regard, we welcome the development of practical and evidence-based tools by the International Narcotics Control Board, the World Health Organization, the International Association for Hospice and Palliative Care initiatives, such as the INCB Global Learning Program, the World Health Organization guidelines on balanced policies for controlled substances, and the development of essential and expanded palliative care packages. These provide valuable guidance to member states seeking to strengthen national frameworks. These tools can support governments in reviewing legislation, improving regulatory systems, strengthening healthcare delivery, and building the capacity of healthcare professionals. Importantly, they also highlight the value of partnership, particularly the constructive role of civil society organizations and professional networks can play in supporting implementation. Ghana believes that meaningful progress in this area requires sustained international cooperation, knowledge sharing, and capacity building. Platforms such as the Commission on Narcotic Drugs provide an important opportunity to exchange experiences, identify good practices, and work collectively toward practical solutions. As we reflect on the decades since UNGASS, this discussion offers an opportunity not only to assess progress, but also to renew our commitment to ensuring that no patient is left behind when it comes to access to essential medicines for pain relief and palliative care. Ghana therefore welcomes the exchange of perspectives that will take place during this event and looks forward to learning from the expertise of distinguished panelists or distinguished speakers. I thank the organizers for convening this timely discussion, and I wish you all a productive and insightful event. I thank you.
Thank you. Thank you, Ambassador. And now I'm going to present my my slides. Sorry. So thank you for that wonderful introduction. And I'm just going to say a few things about the International Association for Hospice and Palliative Care. My name is Catherine Pettis. I'm the Senior Advocacy and Partnerships Director. And I'd first of all like to thank all of our sponsors, which is the missions of Belgium, Canada, Ghana, and South Africa, the INCB, the UN Office of Drugs and Crime Young Doctors Network, and they are all helping to co-host this webinar. We also have many civil society organizations co-sponsors, as you see from the logos on the screen. I'm not going to name all of them because there are just too many, but they've all been faithful partners in this, and they understand the importance of this issue of supporting states parties to operationalize their commitments under the drug control treaties, which is to ensure the safe and rational availability of controlled substances for medical and scientific purposes. It's an urgent issue that concerns all of us because most of us and our loved ones at some point are likely to need them in some point in our lives, whether it's for surgery or at the end of life or for mental health treatment or for whatever else that controlled medicines are routinely used for in many countries. So before introducing you to all the other panelists, I'll introduce you very briefly to the International Association for Hospice and Palliative Care, the organization that's co-sponsoring this. We're a global organization with more than 1,400 members in 156 countries, number that changes from day to day as people join. We're a non-state actor in official relations with the World Health Organization and a civil society in consultative status with the Economic and Social Council. And this status gives us the legal status to advocate at the UN for improved availability of palliative care and essential controlled medicines. And that explains why we have side events like this. And we also have an MOU to collaborate with the International Narcotics Control Board, which you can see us signing on the other side of the screen to collaborate in events such as this. We were very involved in the UNGASS process. I was here for 2 years helping to prepare the document. And as you know, it took 2 years here in Geneva and New York with tremendous involvement of civil society. I was on the Civil Society Task Force. And we generated this wonderful Chapter 2, which is an unprecedented new agreed language on controlled medicines availability with programmatic recommendations to member states. But member states have been slow to implement them. And I think part of that reason is because they haven't had the tools. And we're going to present some of those tools today. You will hear from INCB. You will hear from Dr. Deos when he comes from the plenary, because he's presenting at the plenary. And you will hear from the Young Doctors Network, you will hear from the International Federation of the Red Cross, and all the panelists will tell about these new tools that member states can use to implement their commitments in the UNGASS outcome document in New York in 2016. So the panelists, you've already heard from Her Excellency from the Ghana mission. We are going to hear from Dr. Emmanuel Lurica, who's the former executive director of the African Palliative Care Association. We met years ago in Kampala and we've been friends ever since, but he's now a member of the International Narcotics Control Board. So he will be presenting on the INCB and the learning program. We were going to hear from Dr. Dilkushi Pavendra, but because of the plenary negotiations being changed to today for our item 5D, she is in the plenary, and Dr. Deas, who is actually in charge of the Essential Medicines Department at WHO, will be coming back from the plenary to present on the new guidelines. The WHO published at the end of last year the balanced policy guidelines for member states, which are really excellent and very precise. We also collaborated on that. You will hear from Professor Lucas Rodbrook, former chair of the IAHPC, my organization. He was the chair of the board, a professor of palliative medicine in Aachen. And Dr. Brandon Maser from the Young Doctors Network in part of the UNODC, Ms. Gabriella Poller-Hartig from the International Federation of the Red Cross, and Her Excellency Caroline Vermeulen from the Mission of Belgium will close us out. So we have a wonderful panel. We're going to get going. I'm going to stop sharing. And Dr. Emmanuel, you have the floor.
Thank you very much, Catherine. Good morning, everybody. And it's nice to be here. I come here on behalf of the INCB president, who is engaged in other activities at this event. Distinguished colleagues, partners, and friends, it is a pleasure to address you on behalf of the International Narcotics Control Board. Above all, I'm pleased to be among friends and long-standing colleagues from the International Association for Hospice and Palliative Care, with whom I worked during my role at the African Palliative Care Association to push the palliative care agenda. As a medical doctor myself, I have seen firsthand the crucial role that these medicines play in alleviating suffering in the population that I cared for. Substances under international control are indispensable for the treatment of pain and other symptoms in patients who need palliative care, and in the management of other situations like patients with mental health issues, and in the context of surgery and anesthesia, as well as among those who are being treated because of the history of drug use. And as the INCB has said previously in all its reports, these essential medicines remain inaccessible to many patients, particularly in low and middle-income countries. The reasons are complex. They range from regulatory to supply chain barriers to insufficient training and persistent fears of diversion. Addressing these challenges requires practical, coordinated, and sustained action among the states. The year 2026 marks the 10th anniversary of the United Nations General Assembly Special Session on the World Drug Problem held in 2016. The outcome document adopted at that session remains highly relevant today. Its commitments were reaffirmed in the 2019 Ministerial Declaration and further strengthened by the 2024 high-level review. Central to these commitments is the principle of a balanced approach, and as you will hear from our colleagues from WHO also emphasize, ensuring both the prevention of misuse and the availability of controlled medicines for legitimate medical and scientific purposes. A decade on, INCB data continue to show persistent regional disparities in the consumption of opioid analgesics and psychotropic substances. These disparities translate directly into unequal access to pain relief, mental health treatment, and care for substance use disorders. There are encouraging signs, however. In several regions with historically low consumption, per capita availability of opioid analgesics has increased, although these improvements often start from very low baseline and remain insufficient to meet medical needs fully. They represent important progress. At the same time, consumption remains heavily concentrated in a small number of regions, while access in others, particularly parts of Africa and Asia, continues to fall far short of requirements. One contributing factor is that more than 80% of the morphine manufactured globally is not used directly for pain relief, but is converted into other substances such as codeine. The board has therefore called on manufacturing countries to increase the production of affordable morphine preparations, specifically for pain and symptom management and palliative care, and to ensure equitable distribution. To support governments in addressing these gaps, the board has strengthened its capacity building efforts through the INCB planning program. This initiative, as you can see on the screen, helps national authorities build regulatory and monitoring capacity and improve reporting on the illicit trade in narcotic drugs, psychotropic substances, and precursors. In 2025, the INCB planning delivered targeted training to competent authorities in the Horn of Africa and in Francophone African countries. Through its e-learning modules and in-person activities program, the INCB contributes directly to improving availability of controlled medicines. We encourage all member states to engage actively with this initiative as a concrete step toward reducing disparity in access. In closing, let us reaffirm a simple but powerful principle: no patient should be left behind. As the international community advances the implementation of its shared drug policy commitments, the board calls on governments to fully apply international drug control conventions, ensuring not only the prevention of misuse, but also the safe and adequate availability of these medicines for pain and palliative care in order to safeguard the health and welfare of mankind. Thank you for your dedication and for the indispensable work you carry out in the various areas of the world. Thank you very much.
Thank you very much, Emmanuel. It's very good. And we really appreciate the support of the INCB in this work. And it's great to have you as part of the INCB now. And since Dr. Deus is still in the plenary and hasn't joined us yet, I think we will move on to Dr. Lucas Rodbrook, who is going to present on the essential and expanded packages for children and adults, which is a new tool that has been developed through a multi-stakeholder collaboration of universities and researchers. Dr. Lucas, you have the floor.
Thank you very much. And Madam Ambassador, dear colleagues, ladies and gentlemen, first of all, great thanks to Catherine for organizing this session and putting it into motion, but also to INCB and WHO for supporting this important work. What I'm going to present covers a range of work projects with WHO, but also with other partners, for example, the Lancet Commission on Palliative Care. I think opioids are among the oldest medicines known to mankind. This is a picture of the opium capsule being used to generate opiates. And we all know about the importance of opioids for the treatment of cancer pains. But I think it's important to realize that there's also other illnesses that require controlled medicines or other medicines. Could you, next slide, please? For example, this is an emerging topic in Germany where chronic lung disease like COPD is increasingly accessing palliative care, and they also require opioids, though in a much lower dosage. For example, this is an example from a patient admitted to the palliative care unit, a young woman who got initiated on morphine and then wrote in her own blog that 20 milligrams per day were sufficient. With that, she could live again and be mobile again. Next, please. We have to realize that also communicable diseases such as HIV/AIDS are an important source of suffering. And this, for example, was a patient I met in the Gambia, actually a refugee from Sierra Leone who had come to the Gambia, was experiencing not only physical symptoms but also social stigma. And we have to realize that for these patients as well, controlled medicines such as morphine are important for pain relief and relief of breathlessness, but they also require other medicines. Next, please. And even more important than that, this was a colleague from India who took me on a home care round. On the right, you see Chitra Venkatavaran, who then introduced me to this nice couple, and the husband had a psychiatric illness, the woman had renal disease, end-stage renal failure, and they both require medicines such as neuroleptics or diuretics, not controlled substances, but essential packages need to encompass also these classes of medicines in order to provide palliative care to this broader range of suffering with advanced illnesses. Next, please. This was the reason why the IAHPC was really happy when in 2012 we were asked by WHO to submit an application for essential medicines for the WHO essential medicines list. And we managed to get a whole new section on pain and palliative care into the EML in 2013, including these substances that you see summarized here. Morphine as the standard main analgesic as a controlled medicine, but also other medicines for other symptoms. To be very honest, many of these medicines had already been included in other parts of the essential medicine list, but compiling them in this separate section, in this new section, really was an important step to make people realize that this is the armamentarium you need for to be able to deliver effective palliative care. Next, please. The list has by now been augmented by other opioids such as fentanyl and methadone. Also, oxycodone and hydromorphone have been named as alternatives to morphine if available, and also some other medicines have been added to the list. So this is a living document, and I'm really happy that in 2025 this still is very useful for governments and other stakeholders. Next, please. In a similar vein, the Lancet Commission on Access to Palliative Care and Pain Relief drafted an essential package with medicines, but also with equipment and staff. And you can see that the list is nearly synonymous with the WHO one. The blue highlighted medications are the ones that are different from the WHO list. But the baseline is that there is really a core set of essential medicines which everybody agrees to is very important. Next, please. And it's also not expensive to do that. Even if you calculate in cost of staff and equipment, then the costs per capita are still negligible. So it's not a thing that poor countries say that they can't afford this, that they have to spend their money on other priorities within the healthcare system. This is really a very small part of the healthcare expenditure, which then also saves money at other areas of the healthcare system, or actually in other areas of the country budget, because, for example, then relatives don't have to stay with the patient to care for the suffering patient, but could go to work again. Next, please. In a new step, we took the work up on the essential packages within another major funded project with other partners, and the IAHPC part was to draft essential and expanded packages for children and adults. We used a rather elaborate consensus process, so we had a small steering group with 9 people who identified the substances that might be useful from the essential lists that we had before. Then we had large consensus panels with 89 people, experts for the adults, and nearly 50 for the children. We revised and consented the packages and then ran that through clinical practitioners experienced in palliative care, taking care that they really represented global and across all income groups countries. And we had again 26 experts for the adults and 18 clinical experts for the pediatric section. Next, please. This is the result. So from the essential package list that we had before, only 2 medicines were withdrawn, and otherwise the list is pretty much the same as the Lancet essential medicines list, including morphine as a controlled medicine. We took great care that we focus on cheap generic morphine, also in relation with the overdose crisis in North America and some Western countries. To prevent that, cheap generic morphine is a good approach to make sure that there's no pharmaceutical gain, no company making benefits from this. And it's really one of the cheapest medicines available. And this is really one of the really essential parts in this list. Next, please. The pediatric package, this hasn't existed before, so we were happy that we are able to introduce this as a specific pediatric tool. It's rather identical with the adult one. There are a few changes, but not major ones. But it's also the fine print and details that the application forms and the dosages obviously have to be different with the pediatric community. Next, please. This is this is not from the Lancet report. This is actually from the new essential packages, the suggestions for equipment and human resources, staffing. Equipment is in part really basic. So it's adult diapers, for example, thermometers and a flashlight. So this is really basic caring maintenance products. But to be very honest, there are parts of the world where access to these essential equipment things is not guaranteed, and would really improve if, for example, diapers or substitutes made from cotton and plastic bags would be available. It also includes an opioid lockbox. If you use controlled medicines such as morphine, you should have also safety measures in place like an opioid lockbox. Most of these equipment things are not that expensive if produced in bulk or purchased in bulk. And also the human resources, where I thought that in a high-resource country like Germany, where I work, this would really be expensive to have all these human resources available. But actually we found that if we calculate costs, that in low-income countries, lower and middle-income countries, these human resources must not really be overly expensive and are really affordable. In part, like pharmacists and psychologists, for example, you probably don't need them in the core team all of the time, but you would need access to specialist advice from pharmacists and psychologists and social workers trained in palliative care. Others, like doctors, nurses, and community healthcare workers, definitely have to be available on a primary care level. Next, please. The expanded packages, I won't go into details. That obviously includes a lot of alternatives, a lot of additional medications, and same for equipment and human resources. You would also have some more to add on for the expanded packages. So if countries are able to afford more than the essential, then there are suggestions that can be followed for country lists. Next, please. We want these packages to be used for governments to model their national lists after that, essential and expanded lists. We also want them to use to be used by stakeholders who can use this to advocate for the implementation of really essential, but also of nice to have expanded modalities. And we also took care that we want to make this useful for clinical healthcare workers. So the IAHPC has also implemented a manual for the use of the essential medicines, which is available as a PDF file that you can download, but also as an online version shown here as an example on breathlessness, where the application for opioid-naive patients is shown in a very easy and rapid to use manner. We took a look at, next slide please, we took a look at whether the essential medicines are available. We used our expert panels on that, and you can see that really a lot of the opioids are available, even from the expanded packages. Though, for example, this is the number of participants that said this is not available in my country. So you see that hydromorphone, for example, is lacking in nearly half of the respondent settings. Next, please. But also injectable morphine. Next, sorry, immediate release, not injectable, oral immediate release morphine is lacking in about 6% of the respondents. And you may say that is only a small percentage, 90% would have it available. But this is one of the most essential tools in palliative care. You can't really have symptom control without oral immediate release morphine, and that not being available in some of the expert settings really makes me worry a lot and tells me that we still have a way to go before we can lean back and enjoy the implementation of palliative care. Thank you very much, and giving back to Catherine. So yes, this is the last slogan, something I saw in a small hospice in Uganda, saying that we can't probably do everything for anybody, but we do as much as we can, as long as we can, for as many as we can, as good as we can.
Thank you. Thank you. Thank you, Lucas. That was wonderful. And you can see from Dr. Rodbrook's presentation that there's this really basic package. So low-income countries can afford it. I think it's 1% of the health budget. It's been very basic. And then if you have more income, there's the expanded package for adults and children. So basically what we want to do is make sure that member states don't have an excuse not to implement their commitments from UNGASS. And now there's a perfect segue to Dr. Deus, who just joined us. He's the head of the WHO Essential Medicines Division and is going to tell us about the new guideline that's just been published so that member states can develop the policies to implement the packages that you heard about from Dr. Rodbrook. So that tool will help to implement the tool that came before. So Dr. Deus Shalini is going to share your slides if you would like to just talk about the guidelines and the main recommendations of the guidelines for governments.
No, Mike, I can speak from here.
Oh, yeah, we don't have mics.
Okay, okay.
You have the floor.
Thank you so much. I think my voice is loud and clear.
It is.
It's always a pleasure to speak to colleagues on such an important topic. Starting and setting the scene is to say that, as we just heard from the previous speaker, many countries have no access to the medicines that they need to treat and manage the condition they have, including oral morphine and other opioids. And there are many reasons for this, but one of the things is also that drives access and balanced access is an appropriate national policy. And it's important, so WHO developed this guideline that will ensure that there's a balanced national control medicines policies to ensure medical access and safety. Can go to the next slide. So what is the purpose of this? Of course, is to assist member states to develop those policies. And the objectives are clearly two. Any time you avoid, you don't achieve that balance, something will go wrong. And often some people have one perspective and not the other. Of course, many countries are playing catch up to ensure access and availability and affordability of medical and scientific for scientific use. We have seen. I was actually talking to my colleague this morning, and he told, whereas I think in my own country, Uganda, where the man comes from, have made some progress in access to morphine, but our neighboring country, Burundi, doesn't have the same. And I was seeing the figures that were presented that low and medium income country access is like 15% compared to what happens in high income countries. So it's always important to make sure that there is availability, but also affordability of this. And also, I was just coming from the plenary on statements on Committee B on challenges. There must be access to conduct the studies to provide evidence to inform policies, whether for increased access or control. And therefore, access for scientific use must not be neglected. And obviously, of course, if there is diversion of these medicines to illicit use, there should be control to prevent against harm. Next. So there are a number of recommendations, but I just highlight a few. And one of the challenges that many countries face is their own procurement systems.
Yeah.
Something.
Okay, I think let me see what I can.
Oh, well, I think it's central. You could keep talking, Dr. Davis.
Yes.
But we've got the online access. I know, but we could address the room. Rather than
So I could continue speaking as it gets on this screen. One of the areas is about procurement, supply chain, and management. And as we prepared this guidance, evidence supported a strong recommendations that reports on current consumption potential need, including adjusted estimates where necessary should be accurate and timely and active monitoring. And there should also be based on needs estimates from epidemiological data, consumption data, and clinical guidelines and service capacity. These are important points, you know. Not sometimes only countries depend on consumption data, but if that means if the consumption has been low, then to perpetually remain low if you only depend on consumption data. But other factors should be. Governments need to update needs to ensure adequate supplies on ongoing basis. It's not a one-time off. It should be an ongoing basis, and if supply and demand or other areas of availability change significantly, because I know you all submit estimates to INCB, and if you come up with an estimate that talk about the need for more quantities, you should not hesitate to timely submit demand your estimates INCB. Because often people, when they need, that's when they say we need to import, and there is a whole process of submitting the estimates to INCB and all that. So again, proactive estimation, and so that import or manufacture, if it needs to be arranged, it cannot be delayed. And then procurement policies should ensure sufficient and high quality, efficacious and safe, effective supply. It's not an issue of just, yes, you need and you should have everything that you come across. Sometimes we've seen substandard preparations also being peddled around, and it's make sure that there is access to high quality process. And of course, again, the health systems and the individual, whether it's out of pocket, need to be able to afford that. Next slide. I think, okay, maybe I was not looking at there. You need to go a little bit behind.
Go back?
Yes, go back. Okay. Another strong about supply chain is when you plan supply, and there should be access, not only those where you have strong NGOs and activists, but there should be geographical supply, because often our countries have limitations and they only pay attention to that one who makes loud noise. But that does not mean that the other people do not need. So it's important that you plan for geographical coverage, and also to prevent wastage. Sometimes you find those, because they are supported, they have a lot, and then just in the next district, they have a shortage. You have expiry in one district and shortage. So I think areas to make sure that there's geographical supply and also there is avoidance of wastage. One of the things that has demonstrated to be helpful is local production, especially of oil morphine. And of course, that should be looked at, and there are a lot of experience around that could be shared where it has been done successfully and with good methods of traceability, but also real-time access and of these important medicines. Next slide. Formulations are important. You know, children are not small adults. Then there should be also appropriate formulations for the situations. You know, packaging to ensure to avoid accidentals. You know, especially if you have the elderly or you want to make sure that you avoid accidental use. And of course, when I was a victim of this, or in my early years, when you are overzealous on this issue, then you recommend tamper-proof measures that actually escalate the costs of them. So that there should also be balance as you try to put those measures to avoid accidental use. Not make sure that you don't increase unnecessarily the cost of those products that will affect accessibility and affordability. And of course, the whole issue about formulation and packaging should weigh the safety benefits against harm and risk of limiting access. The laws where should allow possession, and the statement that we came up, especially during COVID, and as people were traveling and all that, to make sure that there is, if there's a legitimate need for use, the law should allow those who legitimately need those products and have access them to possess them, and without putting those limitations. Next slide. Yes, now it's my screen that has gone off. Of course, scheduling is also important, and priority should be on optimizing health outcomes, balancing, of course, access to clinical need and preventing harm, and all relevant stakeholders should be involved. Often, people neglect, including those caregivers and families that indeed ensure that there is appropriate access to this, and they should be involved in the formulation of policies. And then regulation, of course, on import, and to make sure that the requirements don't overburden, because sometimes we have seen this as an impediment. The requirements that are put are so complex that people say, no, I'm not going to go through this process, and they give up. And then what results is lack of access. Next, I think I'm about to. So prescribing and dispensing, again, just to say that indeed there should be developed an independent experts that should look at your real context. I think in one of the side events earlier, I looked at some appropriate task shifting, looking at the health, because again, if you are saying that these should only be prescribed by experts and professors, and then you have one or two you are in one way putting a limitation to access, but do appropriate task shifting with information and education and training to make sure that there is a possibility to prescribe them and legally access them. So again, the many recommendations, and I have just given you a sample, a flavor of the. I would encourage you to really read the entire guideline, and so it was released at the end of last year, and for the next 4 years, I want to work with you to make sure that countries do put in place these policies, so that at least after 5 years, we should be moving the needle to access and not the absurd statistics that we're seeing. Thank you so much.
We need to wait till the end for questions.
Oh, okay.
Sorry, it's just that we have a couple more speakers, but thank you. I'll try. Yeah, please, if this time, yeah. Thank you, Dr. Diaz. And you can hear from Dr. Diaz's presentation, there is a tremendous amount of complexity here, but that is not an excuse. And one of the ways to overcome that complexity is to have cooperation with civil society. And I must say, I was so impressed when I went to Uganda the first time, and you'd have tables like this, and you'd have narcotics police, you'd have prescribers, nurses, doctors, you'd have all the different elements of civil society that were important in working out how to operationalize those guidelines, because governments can't do it alone, which is why we're always offering to help, because we do have those resources, and frontline providers do have the education to help governments do this. They cannot do it alone. So civil society is very important. Now I'm going to pass the floor to Brandon Mazur, doctor from Canada, who is a member of the Young Doctors Network from UNODC, because he is one of the people, and the Young Doctors Network can help to implement the kinds of things, the essential packages and the policy guidelines. Everyone is needed around the table. Brandon, you have the floor.
Thanks so much,
Dr. Mazur.
Your Excellencies and distinguished delegates, fellow panelists and colleagues, thank you very much to the IAHPC for this opportunity to present to you today. I'm a resident physician in pediatric medicine at the University of Toronto in the Hospital for Sick Children, and I'm also doing a PhD in health policy and global health. And I'm going to present today on the topic of collaborative networks as a policy tool, quote unquote, for achieving controlled medicines access and safety. And we'll give an overview of some work being done by the Young Doctors Network, which is an informal network with the UNODC Access to Controlled Medicines program. I have a 10-minute version of this, but you're going to try and get the 5 minutes. So apologies that I may have to skip some things. Just to start, I have no conflicts of interest to declare and receive salary and grant support from those organizations listed. I also want to start with a quick disclaimer before I begin to note that the views expressed herein are my own and do not necessarily reflect the views of the organizations with which I'm affiliated, nor necessarily the views of the UNODC, the United Nations, or its member states. Just briefly getting into a bit of background. So owing to the tremendous advocacy of IAHPC, UNODC, INCB, WHO, and many other global leaders and experts, many recognize that we are facing parallel global crises related to controlled medicines. First, there's the non-medical use of controlled medicines, which remains prevalent and is growing in many contexts. Second, there's the inaccessibility of essential controlled medicines, which we've heard a lot about this morning so far. But despite coordinated efforts to both improve access and reduce substance-related harms, these problems persist. And one potential reason for this is that these issues can be characterized as so-called wicked problems, which is a concept that has originated within the public policy literature. And like other wicked problems, these intersecting challenges result from endemic and complex systems that are fully understood and interact in complicated and unpredictable ways. And the responsibility of addressing these issues is spread across multiple sectors and organizations and different health system levels. The decision-making context for controlled medicines and for drug policy more broadly is complex and is characterized by conflicting and contested objectives and value-laden decision-making. And this leads to low consensus about how the problems are defined and the potential solutions. One potential solution, though, for overcoming some of these challenges related to wicked problems is the fostering of collaborative networks that cross traditional disciplinary, sectoral, and professional boundaries. Collaborative networks with diverse perspectives can help overcome some of the challenges by contributing to clarification of competing understandings, sharing and integration of diverse knowledge, and the generation of new knowledge and shared understandings. Networks can also help promote innovation and learning and contribute to deep analogical reasoning or foreign knowledge transfer, where lessons are drawn from structurally similar challenges in seemingly disparate policy areas. Networks can also help overcome cognitive biases and overconfidence in a group's beliefs and understandings. Networks can also contribute to progress in more material ways, such as by bridging competing coalitions on a particular issue, supporting the pooling and sharing of limited resources, efficient coordination of activities and economies of scale, and enabling the adaptation and scale of effective solutions. One such collaborative network that has recently been developed for supporting efforts to improve access and safety of controlled medicines is the UNODC Young Doctors Network, or YDN. Launched in 2024, the YDN is hosted by the UNODC program on access to controlled substances for medical and scientific purposes while preventing diversion and non-medical use. The YDN provides an informal platform for physician representatives from UNODC member states to collaborate on research, advocacy, and capacity building. To date, we have approximately 60 members from diverse disciplinary backgrounds and representation from all the major WHO regions. The aim of the YDN is to build bridges among health professionals, drug control systems, and regulatory bodies for action on improving access, as well as addressing diversion and preventing and treating non-medical use. Regarding our activities to date, we held our first in-person meeting at last year's CMD and also are meeting again on the margins of CMD this year. We also delivered an intervention last year during the plenary and have another one coming up this morning under agenda item 5D. We've outlined in our intervention last year and this year 5 priority areas for work across 5 different thematic objectives, including capacity building, research promotion, community engagement and communication, supporting clinical practice and rational medicine use, and policy analysis, advocacy, and reform. Since CMD 68 last year, the network has been engaged in multiple activities related to our objectives, and unfortunately, I don't have time to go into detail about all of these, but some of them include the developments of the YDN regional chapter for Africa, which participated in the technical consultation in October on access and availability of controlled medicines in Africa. We hosted 3 webinars last year on the topic of access, and our members are engaged in several other activities. We're also hosting a side event this Friday. I encourage all of you to come. It's at 10 a.m. in room M6, and hopefully we'll have a flyer to share with the conference shortly. Lastly, another example that I'll close on, some work that I've been involved with personally, with collaboration from Dr. Elizabeth Sands from UNODC and another large team of international collaborators, is work on children's access to controlled medicines. And I won't have time to describe the next couple slides in details, but there are QR codes there, and I'm happy to share the articles for anyone interested, where we recently published a 2-part series in the Lancet Child and Adolescent Health on the topic. So the key takeaway that I want to leave everyone with is that interdisciplinary collaboration is critical for achieving balanced controlled medicines policies, and coordinated research and knowledge translation are needed across policy, system, and practice levels to promote effective policy learning and overcome the challenges of wicked problems, especially for vulnerable populations like children and others that face additional complexity. So I'll leave it on this slide with just the acknowledgements to the countless people who have helped this work along the way, as well as the colleagues at the UNODC program. The QR codes are there again, and my contact is there as well. And I welcome anyone to follow up with me. Thanks for your time.
Thank you, Dr. Mazur. And I really think that the Young Doctors Network is a sign of hope, because it's the young medical professionals, not just doctors, but nurses, pharmacists, social workers, spiritual care providers, who are going to be the next generation to operationalize the tools that we've we've heard about today. And to close us out is Ms. Gabriela Poller-Hartig from the Austrian Red Crescent. She's going to tell us about a tool that the Austrian Red Cross is using. So you have the floor. Thank you.
Thank you. Thank you very much, Catherine, for the invitation. Yes, I'm focusing on a rather practical tool to bridge gaps. It's about palliative care in communities. Maybe a couple of words about the International Federation of Red Cross and Red Crescent Societies. We are a network of 191 national societies, and we have a strong local presence in the countries we work. With more than 70 million volunteers worldwide, many of them are community-based health workers that are deeply rooted in their communities. We are often able to reach people where formal health systems cannot. In 2024 alone, the Red Cross and Red Crescent Health Services reached around 200 million people worldwide, and 14 million received mental health and psychosocial support services. Despite the commitments in the UNGASS outcome document, palliative care remains unavailable to the vast majority of people who need it, as you all are aware of. Only 14% of people in need receive it, and most of those without access in low and middle income countries. This represents one of the greatest inequities in global health today. One practical way to address this gap and to help implement the commitments made in 2016 is through mobile palliative care teams working in communities. Allow me to share an example of the Austrian Red Cross. We have mobile palliative care teams for around 3,200 patients each year. In cooperation with other organizations, they help ensure palliative care coverage across the country. The teams are multi-professional, consisting of physicians, specialized palliative care nurses, and social workers. Together, they address not only medical needs, but also psychological, social, and organizational challenges faced by patients and their families. The service is free of charge for patients and for the families. The work includes symptom control, particularly managing pain, breathlessness, and severe nausea, care coordination and case management for complex situations, and psychosocial support, including counseling on social benefits and support for families during the final phase of life and in bereavement. The key strength is their close interdisciplinary collaboration, which allows the teams to respond holistically to the needs of patients and families. At the same time, the demand for the services is increasing. Aging populations, rising cancer diagnosis, and improved treatments mean that more people live longer with serious illnesses and require palliative support for longer periods. What patients and families often need most is simply someone who is there. Unlike many other care settings, mobile palliative teams can take the time needed for conversation, for counseling, and for emotional support. Much of the work also happens through phone calls, helping families manage crisis and reducing anxiety. Mobile palliative care teams therefore represent one of the most important support systems for seriously ill people living at home, because they combine medical expertise, social support, and the time that patients and families urgently need. Time to listen, time to support family, and time to ensure that no one faces serious illness or the end of life alone. Therefore, mobile palliative care teams represent a practical and scalable tool to help member states translate the UNGASS commitments on access to controlled medicines into real improvements in people's lives, while advancing universal health coverage and dignity in care. Thank you.
That is a wonderful tool. Thank you. And I wish we could see that replicated in other countries. So you may be hearing from some member states. Yeah. So finally, Ambassador Vermeulen from Belgium, a wonderful supporter of this issue, is going to give the closing remarks. So you have the floor, Ambassador.
Thank you, Dr. Penitz, and dear panelists, ladies and gentlemen in the room, and also dear participants online. First of all, I would really like to thank the International Association for Hospice and Palliative Care for organizing this discussion, presenting its report, and also commend you for all the work you and your members do across the globe. So we are 10 years after this United Nations General Assembly special session on the world drug problem. And we see that the access to controlled medicines for medical and scientific purposes remains really a key pillar of the balanced drug policy. The commitments that we made in 2016 were very clear that member states must ensure the availability of these medicines while preventing their misuse and diversion. This also was said by you to have this balance. But unfortunately, we still see significant disparities. For many patients suffering from cancer, severe pain, or requiring palliative care, access to essential medicines remain far from guaranteed. And bridging this gap requires turning policy commitments into practical action. In this regard, Belgium would like to highlight a regional consultation on access and availability of controlled medicines for medical and scientific purposes in Africa, which took place here in Vienna last October in the margins of the thematic debates of the CND. The chair summaries was published as a conference room paper, and this consultation that was co-organized by UNODC, the African Union Commission, and Belgium brought together policymakers, regulators, and clinicians, also the Young Doctors Network, to discuss the concrete barriers that limit access to controlled medicines in many countries. At that time, the participants highlighted a number of persistent challenges: the restrictive legislation, the limited training for health professionals, insufficient data systems, fragile supply chains, and the continued lack of appropriate pediatric formulations. At the same time, the discussions made clear that the tools to address these challenges already exist, but what is needed is a stronger policy coherence, better data systems, capacity building, and closer regional cooperation. Another important lesson from these discussions is also the need to invest in people, and this is why Belgium is also one of the supporters for the African chapter of the UNODC YDN, as mentioned by Dr. Maser. We count on these young health professionals to translate this policy into practice. Ladies and gentlemen, a truly balanced drug control system is one that prevents diversion, but also one that relieves suffering. The report presented today, together with initiatives such as the regional consultation in Africa, helps us to move closer to this goal. As Belgium, we remain committed to working with the UNODC, the WHO, INCB, and the partners around the world to ensure that these commitments made translate into real improvements for patients. Many thanks for your participation, and I'm sure that also this side event was a step in a good direction. Thank you.